Hello, everyone. I'm Vincent Atchity, President and CEO of Mental Health Colorado. Thank you so much for joining our virtual conference series on women's well-being. This free conference series will offer 60-minute afternoon presentations and discussions from today, Tuesday, through Friday. Experts by experience, advocates, practitioners, and others will address and discuss some of the unique mental health experiences of women and other people of marginalized genders. Thank you all so much for joining us today, in acknowledgement that women's rights are a mental health matter. Please invite your colleagues and allies to join us this week, and please know that each of this week's summits will be recorded and will be made available on our website indefinitely. Today, presenters will talk about eating disorders, weight stigma, mental health treatment equity, and vulnerability in brain health. Tomorrow, Wednesday, our presenters will talk about criminal justice and empowerment, in addition to perinatal well-being and environmental and social supports during pregnancy and postpartum. On Thursday, we will hear about intimate partner violence prevention, about working moms and burnout, and about trauma recovery and resilience. Finally, on Friday, we will hear about sexual assault prevention and perinatal violence prevention. Before we get started, I want to thank Dr. Jen Leiferman, Director and Founder of the Population Mental Health and Wellbeing Program at the Colorado School of Public Health, and Dr. Kim Gorgens, Professor of Psychophysiology, Clinical Neuropsychology, and Psychology of Criminal Behavior at the University of Denver, for their partnership in assembling our roster of experts for this week's series. I also want to thank my colleagues at Mental Health Colorado, especially Lauren Snyder, Emma Troten, and Adam Goss for all their efforts in making this series possible. Thanks again to all our presenters and participants for joining us this week. Please know that our advocacy work is possible thanks to the generosity of our partners and allies, and we thank you for any donations. In this historical moment of persistent and emergent violence on women's rights and personhood, globally and domestically, from Iran to the US Supreme Court, we aim to promote more holistic comprehension of women's mental health needs in the interest of advancing well-being and empowerment, especially in anticipation of the midterm elections. If you haven't registered to vote, please do so without delay by following a link that we'll put in the chat. Make sure that your voice is heard. As you listen to our speakers, please use the Q&A function to ask any questions. We'll pause for questions after our second speaker before shifting topics, and we'll have a few minutes for questions again after our third and final speaker of the day. With that, it's my great pleasure to introduce our first speaker before going off screen to listen attentively. I'm happy to introduce Serena Nangia, Marketing and Communications Manager from Project HEAL, who will be speaking with us about eating disorders and mental health treatment equity in 2022. Thank you so much, Serena, for joining us. It's all yours.
Thank you for having me, and thank you all for joining and listening. I'm really looking forward to speaking today and would love to interact and answer questions at the end of the second session, and also happy to be around for more questions in the future. So let's share my screen and make sure it works. Can you see? Okay, I'm gonna go as long as you can't see my speaker notes. Let me know if you can, Vincent.
We're good. We
okay, perfect. Okay, so today I'm going to be talking about eating disorders and mental health treatment equity in 2022. My name is Serena Nangia. I use pronouns she, her, and I am an activist and an advocate by trade. That's what I do for a living and for my life. And I'm also an expert on weight stigma and fat phobia. I'm an advocate for eating disorder recovery. And like Vincent said, I am the marketing and communications manager at Project HEAL. And Project HEAL is a really great organization, very much like Mental Health Colorado. We focus on equity and getting people access to eating disorder treatment who might not normally get access to it due to financial and systemic barriers, and we get it access to it for them for free. So I'm also the reason I got into all of this work. I'm the older sister of an eating disorder survivor My younger sister Ellen, struggled for over a decade and is now in her senior year of college studying to become a doctor who will know about eating disorders because of her own experiences. And she's also in long-term recovery. So I'm very glad to say that. So we are going to be having another session on eating disorders right after this, but I wanted to do a little intro into why are eating disorders so important to talk about in mental health practices and behavioral health. So you might not know this, but eating disorders are one of the most deadly, and it's actually the second most deadly mental illness in the United States, second only to opioid use disorder, which surpassed eating disorders about 5 years ago. So up until then, eating disorders were and are, very much deadly. And as far as how people die, it can be a direct result of their eating disorder, but we also know that the rates of successful or completed suicide in those who have eating disorders are very high in comparison to the national average. We also know that at least 1 in 10 people in the US will be diagnosed with an eating disorder in their lifetime. So what we recognize here is that the word diagnosed, right? So a lot of people with eating disorders will never know that they had an eating disorder, might never get access help, might never get a diagnosis. And so if 1 in 10 people in the US have a diagnosed eating disorder, that's 30 million people out of the approximately 300 million people in the US. But that is a very low estimate because we know that a lot of people don't get actually diagnosed. And if we bring in financial and systemic barriers to getting diagnosis or to even recognizing that disordered eating might be causing trouble, if we just recognize that as disordered eating, we expect that most of the United States experiences some levels of disordered eating. And then finally, as we already know, eating disorders are very deadly, but what we do know is that 1 person dies as a direct result of their eating disorder every 52 minutes. So while we're on this call today, hearing myself and other speakers, there will be 1 person that passes away from an eating disorder. And with early detection and early prevention, eating disorders are preventable, or at least we're able to intervene early. And so it's really tough that all of these statistics exist, but it does underpin why eating disorders are such a big deal right now. So we also know that a majority of the people with eating disorders never receive treatment. So it's only between 10 and 20% of people will receive treatment. And if we add in the number of people who are undiagnosed and don't even know that they need help, that number, I'm sure, is much lower. So at Project HEAL, we are working on counteracting a lot of these financial, healthcare, and systemic barriers to accessing care for eating disorders. So what prevents people from accessing care, and what are the barriers? So this is a very small list of barriers. We have many on our website that I will throw in the chat right now, actually, just because I want to make sure that, I don't know if I can actually send it to everybody, but it's www.theprojectheal.org. I'll put it at the end. But we have hundreds of different types of barriers. These are the most important for this conversation. Lydia will be talking about weight stigma more, but I am also an expert, so I like to talk about an expert through lived experience as well. So less than 6% of people with eating disorders are medically underweight, and therefore people who are struggling might not think that their eating disorder is serious if they're in a larger body. Thank you, Emma, or whoever sent that. I identify as someone who lives in a fat body, and I have many friends, and we're about to release a research study on some of these barriers as far as getting access to care. If you're at a low BMI, BMI is widely recognized as a bad indicator of health, but it's also is still used for a lot of insurance authorizations, and generally some medical practitioners might use it to determine if someone has an eating disorder. And even if they're not using BMI, just by the look of how someone looks, we as a society have been taught to assume that only certain people have eating disorders. Binge eating disorder is more common than anorexia and bulimia combined. So binge eating disorder was added to the DSM-5 back in, I think, 2013. But binge eating disorder has existed for a very long time and just wasn't recognized. And even though it is in the DSM-5, far more many people struggle with it than anorexia or bulimia combined. It is still a diagnosis that is not understood by many medical professionals, as well as just society as a whole. We also know that 25 to 40% of people with eating disorders are men or boys. So that research is based on, in the eating disorder world, only 5% of research that exists is on men and boys. So with the only 5% of all the research on eating disorders in the US, we have found that 25 to 40% of people with eating disorders are men. And so I expect that number is quite a bit higher. And transgender and gender nonconforming individuals are at least 8 times as likely to struggle with an eating disorder than their cisgender counterpart. I'm not an expert on this, but what I do know is that there is a big relation between gender dysmorphia or dysphoria and body dysmorphia and eating disorders and body image and all of those things. So if you're interested in that, we have some great resources on our website as well. And finally, Black women are 25% less likely to be diagnosed as white women with the exact same eating disorder behaviors. And that is just a clear example of why some people aren't getting access to treatment. Vincent, will you let me know what time I'm finishing at today? So this is the technical, you can send it in the chat, sorry. This is the technical definition of treatment equity. So behavioral health, this is a definition by the Substance Abuse and Mental Health Services Administration, which is run by the government, some of you might know. But this is their definition. Behavioral health equity is the right to access high quality and affordable health care services and supports for all populations, including all of these marginalized populations. And while it's really phenomenal that they have listed so many different types of marginalized populations, the right for all populations is not necessarily the same as equity. So we'll talk about treatment equity in a second, but I first want to go over this idea of equality versus equity. So equality means that each individual or group of people is given the same resources or opportunities. So if we think about the process of getting access to care, as far as someone starting at a starting line, which is people with the dominant identities, and someone who has marginalized identities, the more marginalized identities they might have, the farther back behind the starting line they actually start. So if we give people the same amount of resources and opportunities, we're all moving forward, but we're not achieving an equal outcome. So equity recognizes that each person has different circumstances and allocates the exact resources and opportunities needed to achieve an equal outcome. So what this means is dominant identities starting at the starting line, people with marginalized identities behind the starting line, and those with dominant identities are given some resources, the resources they need to actually get help, but those who are behind the starting line with marginalized identities get even more resources so that we do have an equal outcome and everybody, as many people as possible, can get access to the resources and opportunities they need to heal. So when it comes to treatment equity, Project HEAL is really big about this, and this is what treatment equity actually is. So treatment equality is the same access to treatment for all, but treatment equity is disproportionately supporting communities that have been marginalized in getting effective and culturally competent care. So this, in order to help marginalized communities find some semblance of healing, they need more support. And this allows people who in marginalized communities would otherwise not get the care that they deserve. And people with dominant identities who are also facing some barriers are still more likely to access care than someone with marginalized identities. So Project HEAL does a lot of things to support people who are struggling and who are in marginalized identities. And what we do is we do give preference and disproportionate support to those who have marginalized identities. And Project HEAL really likes to think we're trying to work ourselves out of a job. We would love to not have to exist, to not have to help people pay for their treatment. We would love if insurance and the systems that exist for their purposes actually worked. And I'm sure any of you who are mental health professionals or have experience with your own insurance or lack of insurance know that it's really frustrating, the fact that we have insurance, we have the system, and it just doesn't work as much as we really need it to. My mentor and one of the board directors of Project HEAL, Ben O'Keefe, said this. He said, "The system is not broken, it's working as intended." So if the system was built to support people with dominant identities and to leave out people with marginalized identities, which it was, in my opinion, then this means that we really need to change the system completely. So Project HEAL has very much a two-pronged approach. We are supporting people in their immediate and necessary needs right now, and we are working on systemic change. So we like to think of the eating disorder field and mental health care treatment and coverage is we're all in this world, in this field that is a boat. The boat has a lot of holes. Lots of people are falling through it. Lots of people are not getting the care that they need, passing away, that sort of thing. Project HEAL, at the same time as plugging the holes through our direct services, which I'll talk about in just a second, we're plugging all the holes as many as possible, but it's still, the boat is still sinking. So at the same time as that, we are building a new boat. And this is what we like to compare to systemic changes that we're working on. We have a lot of projects that we're working on to help create, more access, easier time with insurance, as well as helping more people of color become eating disorder therapists, because that is a really important role that a lot of people of color have been left out of the eating disorder world because of many barriers, including how expensive it is to be certified and trained. I also want to mention insurance, aka the big bad wolf. We all know insurance is a tough cookie. And insurance also plays a very vital role in accessing treatment, because no matter what we do as clinicians, as providers, as treatment centers, as behavioral health hospitals, a lot of people's access to mental health care relies on their insurance. And Project HEAL is doing work to help with these barriers to insurance, but we really need the support of insurance companies, as well as the government, to enforce existing mental health parity acts that require insurance to treat mental health illnesses the same as they would physical health illnesses. So I'm running up on time, so I'll just go very briefly through. Project HEAL's mission is to break down systemic healthcare and financial barriers to eating disorder healing. And Project HEAL's goal is to change that system in the meantime, provide life-saving support to people with eating disorders who the system fails. And I like to take this picture because it's Rebecca Eyre, our CEO, and our DEI consultant, Milton Reynolds. And really, this represents the fact that we are doing internal work at the same time as doing work within our field. We have a lot of different programs that I would love to share more with you about, but I encourage you to go to our website and look at our services. And we're helping people get access to treatment for free, utilize their insurance, and figure out what the hell is going on with insurance, as well as providing free clinical assessments to know if someone has an eating disorder. So please feel free to refer people over to our website as well. You can get involved by becoming a part of the Healer Circle if you are an eating disorder clinician. We help people through pro bono spots donated from from clinicians, and then we allocate those spots to those most in need. So if you are interested at all in becoming a part of the Healer Circle, please reach out to us. For non-eating disorder providers, talk about treatment equity, spread awareness, complicate things, don't make things necessarily easy because they're not. Keep up the important work that you're doing and make sure to rest because that is incredibly crucial that we keep you all involved in the mental health field as much as we can because so many people need help. If you have any questions or need support or would love to connect, would like to connect with me or Project Heal, here is more information to get involved. I encourage you to check out our website or to reach out to me at my email at the bottom. Thank you.
Many thanks, Serena. Thanks so much for joining us.
Thanks.
Please stick around. We'll have a little bit of time for questions after our next speaker. And with that, it's my great pleasure to introduce Lydia Rhino, who's Program Director at the Eating Disorder Foundation, who will be speaking with us about overcoming eating disorders and weight stigma. Thank you so much, Lydia, for joining us today.
Awesome. Thank you so much for having me. I really appreciate it. Hello, everyone. Thank you for joining us. I wanted to introduce, first of all, myself. My name is Lydia Rhino. I am the Program Director at the Eating Disorder Foundation, and a little bit about the Eating Disorder Foundation. We are a nonprofit organization with a compelling message about a life-threatening illness that affects millions of people. Our mission is to be an effective resource in the prevention and elimination of eating disorders through accessible education, support, and advocacy. We offer free services, drop-in support and open community hours, support groups in a safe, non-clinical, and virtual environment. All services right now are currently virtually accessible. We have a couple in-person groups, but a majority of our services remain online to provide a more accessible network of resources. We have workshops and classes, resource referrals, and community presentations. So that's a little overview of what we do here at the Eating Disorder Foundation. Going into more of our talk on overcoming eating disorders and weight stigma. At the Eating Disorder Foundation, we have a pro-recovery focus, meaning we believe recovery is possible. We know that each individual has a unique path to their recovery, and everyone is encouraged to decide what the meaning of recovery is to them. To help individuals find their way, we believe and follow a health at every size, or HAES approach. HAES is sometimes called the New Peace movement and takes the focus away from weight and moves us in the direction of weight inclusivity and respect for our bodies. Health and the health at every size includes our biological, psychological, emotional, and spiritual parts of who we are. We encourage all our mentors to learn about HAES and all of our community members to learn about HAES and be prepared to discuss its principles with everyone should it provide a meaningful part of one's journey. HAES allows us to hold respect, critical awareness, and compassionate self-care at the forefront of recovery. For more information, we encourage you all to visit the Association for Size, Diversity, and Health, their website, which is www.asdah.org. And now I'm going to begin sharing my screen so I can share a little bit more information about the Eating Disorder Foundation. Give me 1 second to get that going. All right. So Serena touched on more of the aspects of eating disorders, but I'll briefly go through in the time that we have. Eating disorders are the development of an unbalanced preoccupation with food, weight, or appearance, greatly interfere with everyday life, relationship sensations, and life experiences, can involve severe mental and physical complications, and can be fatal. We really take a look at the early education and prevention to help with lasting and stable recovery, just to be on that forefront and get in early and start offering the educational services to make sure that communities are becoming familiar with the warning signs of eating disorders and be able to provide some resources available for them in their communities. These are different components of eating disorders we like to take a look at. So this is a continuum that we like to share with folks that maybe aren't as familiar with eating disorders, but it kind of goes along the scope of definitions and different ways that intuitive eating can look like, and then middle ground into disordered eating, and then the diagnoses that can be accommodated with eating disorders. So going into that more serious range of what the progression can either look like or what it can look like from someone that has more of an intuitive eating background, and then more into an eating disorder diagnosable illness. These are the different components of all the things that build up an eating disorder. So there's not just one thing that can lead to an eating disorder forming in one person. So there's usually a component of each of these areas. So biological factors, psychological factors, high-risk vocations, and socio-cultural pressures. I think that everyone wants to be able to label that there's one area specifically that leads to an individual developing an eating disorder, but it really is a combination of all of these different areas working together to create an eating disorder within an individual. This is the part that I really want to focus on, which are the dangers of weight stigma. So looking at BMI as not a factor of being able to be diagnosed, and really taking a look at that HAES identification for being able to assess one's wellness. And some of the facts that have been shown with that are studies show that medical providers associate patients' weight with negative traits. 37 to 40% of people over their BMI reported being teased about their bodies. Anti-fat bias and fat shaming can have negative consequences on quality of care. So really looking at all of these different aspects and how that plays into an individual's experience within the healthcare system, and being able to get proper care for what they are needing, and being able to be properly diagnosed with either an eating disorder or any other area of health. But not using the BMI as a marker specifically for being able to be diagnosed. Health at Every Size provides and respects and celebrates body diversity and is critically aware of cultural assumptions, eating in a flexible manner that values enjoyment and honors internal cues of hunger, satiety, and appetite while respecting the social conditions that frame eating options. We want to take a look at weight not being the only marker of health. Weight can't be a conclusive measure of a person's well-being, their life, or their worth. Health, wellness, and fitness is defined differently and looks differently for everyone. This is a very important one that I look at a lot, and taking in a person as their wholeness and not looking at one area specifically, being able to use that as a measurement for whether they are healthy or any of those words that go along that aspect. So having excess weight is not a moral failing, and having a mental or physical illness is not a moral failing. Really making sure that folks know that those things are not part of their morality, and that doesn't make them a good person or a bad person. We're all simply people. Identifying the emotions behind eating behaviors and body image. Talking about struggles with food and body image for the first time can be the most difficult part. So all it has to start with is a conversation. We encourage a focus on values that don't center around appearance, which we recognize that these things can be very difficult in our society, especially with more introduction and more spent time on social media apps, or just engaging more in a culture that talks a lot about not only body image, and the way that we perceive people based on their image, but also around food and wellness as a whole. and really being able to talk about the emotions that come up and introducing those conversations into spaces so that people feel like they're able to have those discussions and less around the isolation that may come with having difficult emotions that one may find difficult to talk with people that are casually talking about their health and wellness endeavors in an unhelpful way. So what we really like to also focus on, and being mindful of time as well, is acknowledging differences in body types, shapes, and sizes without judgment, avoiding assigning moral value to food choices or demonizing certain food groups. There are good versus bad, clean versus dirty when it comes to food. So really looking at not having any of those labels in there, because then we don't want anyone to associate whether if they are eating what others they have heard deemed as a bad food, then if they identify as enjoying that food, internalizing that label and really having it become part of their identity. We like to assure that talking about struggles with food and body image for the first time can be the most difficult part. And we want and would hope for everyone to be a trusting person to be able to host this conversation. And I know that that's something that we all strive to do here as well. We encourage a focus on values such as relationships. This can also be other parts of their life that an individual may enjoy. I know that for me, a value of mine is being outside, connecting with people that falls into relationships, but really looking at the depth of my relationships is important and being able to support one another. I also know that honesty and authenticity are very important to me. So really looking at whether my discussions that I'm hosting are based around those areas and maybe not having and leading away from conversations that are more geared towards appearance or any of those conversations. Assure that students or people in your community that are dealing with mental health challenges are not uncommon or abnormal, and that these are just as important to address as physical illnesses. One of the things that I always like to talk about is that if an individual has a broken bone, we want to make sure that they get all of the support that they can, go to the correct doctors, get it lined up in a cast, and go through that whole process of also being able to be acknowledged as going through something difficult and getting emotional support. Mental health challenges are not unlike that at all. And I would really hope to be able to see in the future that we're able to address that the same way and encourage that growth and that resiliency in the same manner that we do with physical illnesses. We understand that the person may not yet want to get well and takes comfort and control and feel safe in the rituals of this disorder. This is very common. I've known many folks that the eating disorder is a very comfortable place for them to be. And it's all right if they're not ready yet, and we can be someplace and we can be somewhere that people are able to acknowledge their feelings and to that not to be weaponized against them. And we can recognize that this is a really tough place to be and sit with them in that. And that doesn't mean that they're not also in their own process of beginning their recovery journey. And we emphasize the seriousness of the topic, but maintain a hopeful tone. Eating disorders are serious issues and recovery can be difficult, but it's possible if the student or individual gets the appropriate support. I think this is something that we can view really negatively, especially in the media when talking about eating disorders. And I never want to make it light and say that they're not serious, because obviously they are, and recovery can be difficult, and it is extremely full of hope and full of folks that are very determined to making sure that everyone has adequate support and appropriate treatment teams and providers that are well equipped to be able to handle individuals and the severity of the illness. And I know that everyone here at EDF, we all know that everyone's recovery journey looks different and recovery process looks different. And that's what's also so exciting about recovery, is that we all get to define it however we see fit for interacting with our lives. And we love to hold on to the hope that there is recovery available for every person struggling with an eating disorder. These are some resources that we have available within our specific Denver community. We have some of them listed here. So we have Acute, Children's Hospital, ERC, ED Care, La Luna is in Boulder. And then we have some of our outpatient services, such as the Gaudiani Clinic, ED Care, ERC, La Luna, and then obviously the work that we do here at the Eating Disorder Foundation, the National Eating Disorders Association, which is a national group that provides services, and then also Project Heal as well, which Serena spoke to just a little bit ago. If anyone has any questions, please feel free to reach out to myself or any of the other staff members here at the Eating Disorder Foundation. We all do the work that we do because we believe in it and we believe in our community and the bounds towards recovery that we're all able to make when we all stay strengthened together throughout it and providing community and connection. I'll provide my information, probably with the slides or whenever any of the information gets passed out. Thank you all so much for having us here to speak with you all, and I look forward to continuing the rest of the days of our conversations here.
Thank you so much, Lydia, for joining us today and for your presentation. These presentations have been recorded and will be available on our website. We will share those out to all of the folks who've registered shortly. And that will include the slides that Serena and Lydia have shared. If you have any questions, please put them in the Q&A. We can take a minute or two, and I'll just take a moment to mention some of the advocacy work that Mental Health Colorado is anticipating for the 2023 legislative session here in Colorado. We will be working on a bill that addresses treatment and insurance practices related to eating disorders to make sure that there are quality measures in place in eating disorder treatment facilities and adding protections for the LGBTQ+ community. Working on removing the use of BMI as a determining factor in medical necessity and making diet pills and weight loss supplements illegal to sell to minors without a prescription. So this is an important issue for us this year. I'm seeing no questions, and in the interests of staying timely with our program today, I'm going to allow you to follow up with questions with either of our previous presenters and move ahead with introducing our final presenter for today. It's a pleasure to introduce Dr. Kim Gorgens, Professor of Psychophysiology, Clinical Neuropsychology, and Psychology of Criminal Behavior at the University of Denver, who is with us to speak about vulnerability and brain health. Thank you so much, Kim, for joining us. It's great to see you.
Thanks so much. Thanks, Vincent. Thanks to the previous speakers. Oh my gosh, what a lineup, and how cool to get to be featured alongside such experts. I'm going to share my screen and get rolling. What I'll say as a disclaimer is that, as is usually true for me, I've shoehorned 7 hours of content into 20 minutes. So anyone who knows me knows that that is how I roll, but I will make the presentation available. Everything here is hyperlinked. So hopefully, as I'm spinning through some content, a lot of it will resonate. Some of it will be intuitive, and anything that you wanted to follow up on, you'll be able to do that. Vincent, does that visual look okay? I'm guessing it does.
I can see more than just the slide. I can see the next slide and the little line.
Oh, got it. Hold on. Let me flip it around. Let's see if.
There you go.
Still?
Nope, that's it.
Okay, perfect. So thanks for that. Good looking out, good teamwork. I'm going to talk today very briefly about the brains of women and what we know to be true about what's unique about the brains of women, what's protective about the brains of women, and the unique vulnerabilities of the brains of women. First, I thought it might be helpful to speak broadly about traumatic brain injury, which is my area of expertise. I've been working in the brain injury space for more than 2 decades in my career. We have a number of different community-based research projects here at the University of Denver. And I do this work on a national and with some international partners. So this really is where my heart is. And I'll share with you some of those highlights from that body of research. This is from some of the Colorado data. Traumatic brain injury, by the way, is the application of an external force or a blow to the head. Here we talk about significant injuries are the kinds that are more than just a traditional concussion or getting your bell rung. These are the kinds of injuries that we associate with poorer outcomes. So repeated injuries, moderate and severe injuries, just as two examples. In criminal justice settings, between 25% and 97% of people who are involved in that system, the criminal justice system, have a significant history of brain injury. And that number varies based on the setting. The 97% is in a female-specific population. These are some of our Colorado data too. In terms of brain injury history, significant brain injury history among people who are homeless or unhoused. That number ranges from 48% to 74%. It was 74% in research here in Colorado during COVID. 60% of people who have a significant brain injury history also have a comorbid substance misuse disorder, and 60% of folks with a significant brain injury have a history of significant mental illness. So there's tremendous overlap in terms of these vulnerabilities, including in all of these settings. And we're going to talk more about each one of those areas as we move forward. But first, I include this totally tongue-in-cheek. This is actually a screenshot of a book that's available on Amazon. I share it as a glib way to say everything we know about brains is really informed by the study of men's brains. So you don't need to buy a book called Men's Brains. Really, if you pick up a textbook, a psychophysiology textbook or the neurology textbooks, those are informed by largely the study of male brains. So much of what we know in the field of neuroscience is informed by our understanding of male anatomy and injured male brains. And that has largely been driven by convenience populations, so military, for example, and athletes. So settings where men outnumber women, so they have populated a lot of our brain research for decades now. So we're only just recently paying attention to the ways that women might be different. And here I include this as another tongue-in-cheek way to allude to the field's long-standing ignorance about what is unique about women's brains. Here I think it's probably mutually offensive to these two genders, these two binary genders, but you can see that at that time we didn't know a lot about the brains of men or women, but we certainly don't know that much more about women's brains today. So I'm going to share with you a super quick tour of what we know to be true, our growing understanding of the vulnerability of women's brains. And everything we're coming to understand suggests that the experience of women, particularly after brain injury and as they age, is very different than is true for their male peers. This is the world's most complicated slide. I include it really as a nod to a good colleague and a collaborator of mine in Massachusetts, Eve Valera. But this is a picture of why there are differences in the brains of men versus women. And here again, the research is probably lagging by about a decade in terms of the conceptual picture of gender. So here we're talking about sex assigned at birth, so a binary view of gender differences. So someday we'll know enough about the brains of all of the other gender identity statuses. But right now we're only just beginning to learn about this second gender, which is for females assigned at birth. This is a picture of all of the ways that the experiences and biological picture of women is different than is true for men. So I include it really as a way to intuitively highlight how complicated a landscape that is. We know that after injury, women fare more poorly. And this is a really important take-home message for anyone who maybe is listening to select points throughout the presentation. Women are more symptomatic after brain injury, even after mild injury or concussive injury. We used to chalk that up to gender differences. I say we used to, people still do, but we used to think that women were socialized to report their injury-related consequences. So socialized to be more candid about the report of depression or sadness or irritability or difficulty concentrating. And only recently did people start to wonder if women might actually be more symptomatic after injuries. And again, that's not true for the field at large. So there are a lot of folks who continue to rely on these weird old gender tropes. So in any case, women have a greater inflammatory response to injury, which can be good in terms of injury recovery. It can also be very bad in terms of chronic inflammation, which is related to all manner of other poor health outcomes. And importantly, women are overrepresented in the rates of people who develop early onset dementing disease after brain injury, which is really the headline that the NFL talks about in terms of their retired players. And that's a lightning strike for male players. Statistically speaking, women are much more likely to be overrepresented in that group of that fairly low base rate group of early onset dementia patients. So let me talk about one of the ways that women get injured predominantly, and that's related to interpersonal violence. Of course, we could talk for another hour about interpersonal violence. Here, I'm just skimming through the research to make a point of the relationship, the importance of the relationship between exposure to interpersonal violence and poor health outcomes. And that is likely bidirectional and related to intervening variables of all manner. Some of which you've already heard about today. But the slice that I want to pull out for you is the brain injury component. So we know that there's something unique about exposure to violence-related brain injury relative to exposure to brain injury from any other mechanism. So a car accident or a fall, for example. People with violence-related brain injuries do more poorly after injuries than their car accident injury-related peers. They have poorer social outcomes, they have poor, which includes poor income, divorce, which is a tricky one in terms of outcome variables with respect to interpersonal violence, because sometimes that can actually be a good thing. But changes in socioeconomic status and unemployment are equally usually poor outcomes. And if you look at the rate at which women are exposed to violence-related brain injuries from in this context of a personal relationship, an interpersonal relationship, those rates are extraordinarily high. In some, depending on where you poll women, so women in shelters, about 92% of them have a significant history of brain injury. And in emergency room settings, that number hovers around 70%. And I'll share some of our data in Colorado with you in just a minute. But this point about the exposure to multiple brain injuries, and here we define that as exposure to 3 or more injuries in a short period of time. The idea, the clinical rationale, is that if you sustain a second injury before a first injury fully heals, the outcome for that second injury is much poorer. And then certainly if you sustain a third injury in that period of time, it exponentially complicates the recovery from those previous, now 3 injuries. So what you see is that the experience of women exposed to interpersonal violence is one of multiple brain injuries. And in that way, I made a point in a 2020 TED Talk that women exposed to interpersonal violence look like retired NFL players. So I really cannot overstate the importance of being aware of this particular vulnerability, especially as this group of women ages. So for behavioral health professionals and advocates and allies to be aware of how high the stakes are, because these women don't have access to a $765 million lawsuit. This is a piece that my colleague Anne DePrince and I wrote. This was for Scientific American, but it paints this picture of the ways that we have the wrong conversation when we talk about brain injury, that we talk about football players and American football and EU football, and we miss the, statistically speaking, the largest population of people who injure their brains, which are these women who are exposed to violence. It's perhaps not surprising to some of you that the rate of exposure to violence for women surged in really alarming ways during COVID. That was particularly true for some of the more vulnerable parts of our communities. So essential workers, people who were unemployed, people who were temporarily housed. their rates of exposure to violence increased in a really troubling fashion. You can see that this 2020 study that studied people from the start of the pandemic in 2019 found that 64% of folks credited the pandemic to an increase in their exposure to violence. And here's that study that I alluded to a few times, which is the collaboration with Anda Prince. Here is a partnership with the Rosandom Center. We screen women when they present for care at the Rosandom Center. We screen them for all manner of health complications, one of which is brain injury. And we've screened almost 100 women, about 86 women. 87% of them have a significant history, lifetime history of brain injury. 2/3 of them, that injury was related to intimate partner violence, or IPV, and their average number of significant injuries was about 3 for each woman. More than half of them had an incident of that multiple brain injury, which is the 3 or more in a short period of time. And what was really alarming, and this is an area of study that we're only just now starting to really deliberately drill into, which is acquired brain injury. This is a kind of brain injury that you sustain related to lack of oxygen. So for women who are strangled, for example, they risk sustaining an acquired brain injury. So what we found was that 25% of these women reported being strangled in the most recent incident of interpersonal violence, and about a quarter of them, just over a quarter, had been choked in the last 6 months. So here are some of those data in greater detail. One of the areas of research that I feel really strongly about is studying the experience of women who are involved in the criminal justice system. So these are women who are incarcerated, whether they're in probation, some of them are in jail, some of them are on parole. There is a really unique relationship between brain injury and the experience of women in criminal justice, largely because gender differences go away. So the ways that brain injury shakes out in the general population really is not true for a criminal justice population. And for women, that brain injury appears to confer a much greater risk for poor outcomes. And for anyone who didn't already have an intuitive sense that there is an almost 100% relationship in the overlap between being a victim and an offender, I use that term loosely, but the overlap between having been victimized in your past and ending up being the subject of an investigation, a criminal investigation, is about 100%, as we found to be true in our research too. So let me share with you just a few highlights from that study. And I'm, again, I know how quickly I'm moving, and I so appreciate that everybody could hang for it. And don't forget, you'll have the slides. One of my doctoral students published this study several years ago, but she found that women were twice as likely as their male peers to have multiple brain injuries. They were 6 times more likely to have multiple brain injuries related to interpersonal violence. So, and we know that those outcomes are poorer for both of those things. This is a study that we are writing right now, but this is looking at differences between the experience of men with brain injury and women with brain injuries in criminal justice and what sets them apart. What's true is that women with brain injury, significant brain injury history, who are in criminal justice, were much sicker. They were much more likely to have physical health complaints, much more likely to have been diagnosed with a mental illness. For women who were diagnosed with a mental illness, they were much more likely than their male peers with a mental illness to be managed with psychiatric medication. So some of you may have an intuitive response where you hearken that fact back to conceptions of hysteria and a wandering uterus. They're much more likely to have made at least one suicide attempt, to have been the victim of violence as a child and as an adult. And they were much more likely to have been convicted of pretty basic crimes, but have served the same amount of time. So unlike their male peers, they were much less likely to have been convicted of interpersonally violent crimes, for example, but their sentences were the same length. So these women get chewed up in criminal justice, more so even than their male peers who are getting chewed up in criminal justice. So what do you do about it? It's all of the things. It's all of the work that Mental Health Colorado is doing to promote advocacy and to amplify the voices of these women. Really importantly, I want to showcase one. This is a blog post on the Marshall Project, which I'm sure many of you subscribe to. I know that Vincent's work in criminal justice has also been featured here. This was a brain injury survivor who was mentored by a group of us here in Colorado. I was able to put her in touch with a journalist colleague. So this is her first person account of being a survivor of brain injury and the ways that the system failed her. For that reason, she actually wrote this piece of legislation that ran and was passed last year. So Melissa Bickford is her name. And with many thanks to her, this particular Senate bill rolled out this year. The task force is meeting in real time right now. And this bill requires brain injury screening for all victims of violent crime. So a really important precedent. And what's even more important is that this was a stakeholder-led initiative from the very start. So if you're interested in more info about this, about interpersonal violence, about our brain injury research here in Colorado, my colleague and I, Anne DePrince, are presenting next Friday on the 4th. Thursday and Friday are the statewide Brain Injury Alliance of Colorado conference, which really has a stellar lineup. We're presenting on Friday. Love to see you there. And with that, I thank you. Thanks to the Mental Health Colorado team. Thanks to you, Vincent, for your work. Thanks to the audience for having me and letting me talk so fast. And please do reach out if I can answer any questions or if you're interested in contributing in some way.
Many, many thanks, Kim, for being with us and for packing all of that in so efficiently within the time frame and keeping us right on time. We're going to wrap things up for today in just a minute, unless I see some questions appear in the Q&A, and just want to encourage everyone to share the link to the summit with others and join us again tomorrow on Wednesday for presenters on criminal justice and empowerment, as well as perinatal well-being and environmental and social supports during pregnancy and postpartum. And with that, many thanks again to Serena and to Lydia and to Kim. I hope to join you again. There's a question just asking whether the slides recording will be available. Yes, all of this will be available on our website, not immediately, but within the next few days, and will remain there. And we'll send out a follow-up email with the link to folks. And otherwise, we're just seeing applause and thanks and praise, and wishing you all well, and hope you'll join us again tomorrow. Take care.
Thank you.